Hi everyone, it's Dr. Kim. Today we are going to talk about pelvic floor health. So some of you may have been wondering, and I've definitely been asked before, why is a plastic surgeon talking about the pelvic floor? So when I was in medical school, I was really actually quite torn between going into obstetrics and gynecology and plastic surgery. I loved them both. I have always had a very strong interest in women's health and obstetrics and gynecology. In fact, when I finished medical school, I got the awards for both surgery and gynae because they were areas that I had really focused on and dedicated my studies to. As part of my reconstructive practice, so when I was doing reconstructive work, I did a lot of cases with one of my gynecology colleagues who was a gynecology oncologist, and we did quite a few cases together of complex pelvic floor reconstruction, vaginal reconstruction, for tumors or trauma or infections. So it has been an area of interest of mine and definitely an area of study. Obviously, you need to know the anatomy of the pelvic floor pretty well if you're going to do reconstruction and put it back together. So let's get started. What we're going to talk about is review of the anatomy, medical maintenance, the pelvic floor as we age, types of incontinence, treatment options, and then question and answer. So starting off with our anatomy review. So here is a slice through the female anatomy. You will see the organs of the pelvis. So from front to back, we have our bladder with the urethral opening. We have our uterus, vagina, and then we have our rectum and anus. And if you notice, these organs are supported by this sling of muscles, this hammock of muscles, which are our pelvic floor muscles that help to both support the organs up into our pelvis, but also contain the sphincters and the other muscles that we use to control continence. They are opening here into our labia minora and majora. So the two terms, vulva and vagina, are often used interchangeably and used incorrectly. So the vulva is any part of your anatomy on the outside, basically what touches your underwear, and the vagina is on the inside. So when people often mix those up, or they talk about vaginas when they're really referring to vulvas. Interesting anatomical fact, the female clitoris is the only human organ that exists entirely for pleasure. Everything else has a functional purpose. The clitoris is only for pleasure. And it's important to know that there is no normal size for labia majora and minora. Just like how women come in all different heights and weights and breast size and hair color, labia come in different sizes and slightly different shape modifications as well. So a lot of women become self-conscious about that zone, either from the way it's portrayed in pornography or maybe a comment made by their partner, but actually there is a very wide range of what would be considered normal. So though there are cosmetic options and cosmetic procedures that can be done in that area, including labiaplasty, that should only be done for the woman themselves, not in an attempt to treat any or achieve sort of normalcy, given that there is nothing that, no one normal. And the function of the labia is to protect the vaginal opening, to keep it protected. This is looking at the pelvic floor from the bottom, and we've removed the skin and the fat, and what we're looking at is the two layers of muscles, the deep and the superficial layer, as well as the sphincters, the circular muscles that are important for continence, and the white stuff, which is our connective tissue. So we have active support in our muscles and passive support in our fascia or connective tissue. And this is the same all over the body, not just in the pelvic floor. So medical maintenance. We no longer recommend annual pelvic exams. It used to be that women had to go in for a bimanual exam and a pelvic pap smear every year, but we don't recommend that. Currently in Canada, we recommend every 3 years up until age 70, starting at age 21 or whenever a woman becomes sexually active. And beyond age 70, we don't recommend them, assuming that the woman has had 3 normal in a row. The only regular routine exams for vaginal health are our cervical cancer screening with our pap smears and sexually transmitted infection screening with our pap smear or as needed. A pelvic exam should not be painful. If it is causing pain, something is wrong, and you need to tell your physician or nurse practitioner that you are experiencing pain. You shouldn't just grin and bear it because it should not be painful. And remember that vaginas are self-cleaning ovens. They do not need product. They do not need to be steamed. They do not need jade eggs. They do not need a douche. They do not need spray. They do not need anything put in them to clean them. The lining of the vagina turns over approximately every 72 hours, and that contributes to the natural and normal physiological discharge that women experience. Self-cleaning oven, don't use any extra products. Products in that area can lead to irritation, reactions, itching, and actually increase the risk of yeast infection. So what happens to our pelvic floor as we age? Well, first of all, depending on the source, between 25 and 40% of all women over age 30 experience some sort of pelvic floor dysfunction. And that is made worse by pregnancy and childbirth. During pregnancy, the pelvic support system becomes stretched out due to the weight of the growing baby, as well as the hormones that circulate to allow for the tissues to relax and stretch during delivery. Childbirth can lead to direct trauma, including tearing and disinsertion or change in the configuration of the pelvic floor muscles. Now, tears and trauma and episiotomies often heal in about 6 weeks, but the pelvic floor muscles can be left stretched out and weak, and they often don't go back to the way they started. It's the same thing that happens in women's abdominal wall, where we can end up with what's called a rectus diastasis, or spreading of the rectus muscles. The abdominal wall spreads apart to make space for the baby. The same thing happens in the pelvic floor, and sometimes they just don't go back to the way they started. New moms are often told to do Kegel exercises, but postpartum Kegels can be due because it can be painful, it's tender, the muscles are very weak, they're trying to regain their nerve supply, they've been lengthened, and so often new moms don't do them, they do them inconsistently, or they don't do them. This can lead to long-term dysfunction of the pelvic floor. So a study from 2014 looked at women who were complaining of pelvic floor dysfunction, whether that be urinary symptoms or pain with sex, and they found that 70% of those women were unable to perform correct voluntary pelvic floor muscle contractions, even with instruction. So even after being shown anatomy, even after being taught how to do it properly, they simply could not recruit and contract the correct muscles in order to strengthen their pelvic floor. And almost 50% of asymptomatic women, so women who didn't necessarily complain of symptoms, were also unable to perform a voluntary pelvic floor muscle contraction. So this tells you why Kegel exercises don't work that well for many women, because they simply, we can't find the proper muscles to contract them. So in our 30s through 50s, we have a gradual loss in muscle strength and the tensile strength, or the support strength, of our connective tissues. And this happens in the pelvic floor. It happens all over our body. That is the same reason why our arms start to sag and our boobs start to sag and our face starts to fall. In our 40s and 50s, as we enter the perimenopausal era, we have decrease in circulating estrogen and progesterone, and this starts to lead to weakening of our tissues, decreased collagen production. In our 50s, as we hit menopause, we have low estrogen, decreased collagen production, decreased strength in our support tissues, as well as lack of estrogen, leading loss of vascularity in the vaginal lining, which can lead to thinning of those tissues, making them more prone to trauma and dryness. Overall, altogether, this leads to a weakening and loss of integrity of the pelvic floor and the pelvic floor organs, leading to urine leakage, leading to decline in sexual function, and sometimes organ prolapse. So what is organ prolapse? Well, there's 4 different types. So number 1 is called a cystocele, and that is when the bladder actually drops down in the pelvis here and actually push in and impinge on the vagina. When the bladder loses its support, we do not have that pelvic floor to help contract down our urethra, and we can get incontinence as well as sexual dysfunction. We can get a prolapse in our small bowel called an enterocele. We can get a prolapse in the rectum called a rectocele, and a prolapsed uterus. The uterus falls down, leading, of course, to sexual dysfunction, but it can actually pinch in on that urethra as well and lead to incontinence. Now, in terms of our uterus, what happens, or what it's like in our youth, is this is our vagina. The uterus is sitting high up in what we call the vaginal vault, and it's supported by these ligaments, these round ligaments. Most women, after they have a baby and things are stretched out, it drops a little bit into the vaginal vault. We call that 1st degree. 2nd degree, it's dropped down in the vagina, and the cervix is sitting at the level of the introitus. Introitus is the entrance to the vagina. 3rd degree, your cervix is sitting outside, and 4th degree, your vagina is basically inside out. So clearly, that is going to have very significant functional implications if we're leading to these higher degrees of prolapse. And one of the problems that we can develop is incontinence. And there's several different types of incontinence, and they're caused by different things. And that's why it's really, really important, if you're having pelvic floor problems, to be evaluated medically. This needs to be done by a physician, a nurse, a pelvic floor physiotherapist who's knowledgeable about all of the different types of incontinence, everything that can lead to incontinence. There's lots of medi-spas out there and other health or other providers who are not medically trained that are offering cosmetic treatments that simply do not have the training or background knowledge to appropriately evaluate what's happening. So the different kinds of incontinence. So one is called outflow, and basically we have a pinching off here of your urethra. The pee cannot get out, the urine can't get out. You have this constant dribble, 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 and a feeling like you always have to go, you can't empty your bladder. That obstruction can be in the urethra itself, or it can be from one of our prolapses where the uterus is actually pushing in on that urethra. Next, we have stress incontinence, and what that is when we lose our integrity of the pelvic floor. We don't have that structure to resist our increased abdominal pressure. So when we cough or laugh or sneeze or jump and we have that increased intra-abdominal pressure, think about pushing in, and that pressure pushes down on the bladder. We can't resist it, and we get leakage. We can also get a bladder that is irritable or overly sensitive or spasmy. Then the muscle in your bladder is called the detrusor muscle. It can become overly sensitive from infections, or certain neurological diseases can lead to spasms. So diabetes can do it, muscular sclerosis, which is very multiple sclerosis, which is very common in Canada. We can also have mixed incontinence, and that means more than one of these things can be happening at the same time. So for certain, stress incontinence and outflow incontinence are very, very common and happen together because of that loss of integrity of the pelvic floor. And finally, we can have temporary incontinence, and temporary incontinence can happen because of an infection. It can happen because of a temporary lack of mobility. Maybe you broke your leg. Maybe there's a temporary neurological issue, but it's temporary and it goes away. Other contributing factors are some medications like diuretics, which are used to treat high blood pressure, smoking, obesity, diabetes, as I mentioned, excessive caffeine intake, urinary tract infections, constipation and constantly pushing, neurological conditions, excessive fluid intake, occupations with heavy lifting or strain, where you constantly have that increased intra-abdominal pressure, as well as high impact physical activity. And again, this is why it is important to be evaluated by a health professional who has the training and the ability to tease all of this apart and figure out what is actually causing your functional problems so that they can be addressed. So of course, one approach to management is behavior modification. So maybe we need to look at weight loss. Maybe we need to cut back on caffeine or fluid intake. Maybe we need activity modification. We need to change the job or your activities. Next, we can consider Kegel exercises, and I had mentioned these before. So Kegel exercises are that purposeful contraction of the pelvic floor muscles to try and strengthen them and restore and maintain your strength. They were developed way back in the 1940s by Dr. Arthur Kegel, who was an obstetrician in California. Now, up until Dr. Kegel came up with this, most physicians just kind of ignored these concerns as woman problems, female problems. Medicine is rife with misogyny, long history of misogyny and ignoring women, writing them off as crazy, and just ignoring issues they were having. But Dr. Kegel was the first one who kind of made that connection between childbirth and pelvic floor trauma leading to sexual dysfunction and urinary incontinence. And of course, up until recently, women simply did not speak about these things. You didn't talk about sex. You weren't supposed to like sex. And you sure didn't talk about incontinence. And if you did, that was just part of being a mom, and you were just supposed to accept it. But what Dr. Kegel developed was a device which was essentially like the bulb of a blood pressure cuff that we used to blow up a blood pressure cuff, and that was inserted into the vagina, and then women would squeeze, and you could measure, just like on a blood pressure cuff, how much contraction they were getting. And versions of this are still used today. Versions of that device and just Kegel exercises are still used today. The Mayo Clinic recommends 3 sets of 15 contractions every day. So that's about 45 a day. And that's what they feel realistically women will be able to manage and remember to do, 45 a day. But as I mentioned, the problem with traditional Kegels is that it can be very difficult to learn how to contract the correct muscles. I told you about that study that 70% of women, even with direction, were unable to do it correctly. It's hard to remember to do them consistently because life is busy and you've got other things to think about. Pelvic floor physiotherapy is an option, and I don't want to minimize it as an option. It's an excellent option for some women. There are very skilled and dedicated pelvic floor physiotherapists out there, and it's been studied, and there's reasonable evidence for pelvic floor physiotherapy. What it often involves is, again, placing something, not always, but often placing something inside the vagina, whether that is the fingers of the physiotherapist, whether that is a squeezable cone, and again, teaching how to use those muscles. Sometimes we use biofeedback, where actually pads are placed, and you can again watch as different muscles are being stimulated and kind of teach you how to contract the correct muscles. Sometimes they use TENS, which is transcutaneous electrical nerve stimulation, but often it's very superficial. It doesn't penetrate necessarily deeply enough to get into those deep pelvic floor muscles. So pelvic floor physiotherapy can be very effective for some women, but some women are very resistant to that kind of treatment and having someone kind of right up in their business and maybe putting their fingers in there. So definitely, not for every woman. Other management approaches include vaginal inserts like pessaries or bladder support inserts. But some of the issues with these, of course, can be infection. We need to keep them clean. Some women can have difficulty inserting them into the correct place. There can be slippage, and particularly in postmenopausal women, when we have thinner tissues, there can be damage to pressure erosion. This is an example of a pessary. This is a donut one. It's basically put up on the inside to help lift and support the uterus. These ones, this one is almost like a tampon, except it's placed lower in order to push in and pinch in on the bladder. It's a little bit stiffer. This one's disposable. Or this one here, which has little sort of bulges on it that is placed inside the vagina, again, to push in and pinch on the urethra. So pessaries are supporting that cervix back up, whereas these ones are kind of pinching in on that bladder so that it's helping stop. Other non-medical inserts out there are balls that can be put up, and you have to squeeze to keep them up in there. Sometimes they even vibrate. Different weight systems. Right now there's an app out there that's basically like a squeezable tampon that goes in there, and it Bluetooth connects with your phone, and you can measure it on the apps and track it. I suspect it's going to come out that there's some sort of someone watching women squeeze their vaginas. And then, of course, Gwyneth Paltrow and her jade egg craze, which, like I said before, self-cleaning oven, we don't want to stick anything up. Absolutely have to. And then there's disposable products like pads. Depending on how much of an issue, how much leakage, these can really start to add up. So one study looked at sort of mild incontinence to complete incontinence, and it was ranging anywhere from $160 a month to $240 a month. So over the course of your lifetime, if you're starting to use these in your 40s or 50s, this can add up to obviously a very significant amount of money. Other management approaches can be hormone replacement therapy or topical estrogen into the vaginal canal. And then surgery. So there's several different surgeries, including the mid-urethral sling, suspension procedures, bladder neck. Okay, so let's talk about surgical options. We have a quick video here that discusses some of the surgical options specifically for stress urinary incontinence. So you remember that I told you that stress urinary incontinence is that leakage or incontinence that happens with increased intra-abdominal pressure. So laughing, coughing, sneezing, jumping on the trampoline with your kids, at the gym, exercising, that leakage that happens with stress. So we have, again, this is just showing you the anatomy that we already talked about with our kidneys creating the urine, going to your ureters, into your bladder, and then finally into the urethra. So we have, this is our internal sphincter that allows the urine out into the urethra. And this is just going to show you a couple examples of the type of surgeries that can be done. So open technique, where we're actually basically cutting in and putting these suspension stitches in to lift and change the course of that ureter, lifting it back up and giving it support again. It can also be done laparoscopically, so making small little ports, putting in the laparoscopic instruments, and then using that to lift and support that bladder back up. Our sling procedure is done transvaginally, so that is an incision in the vaginal wall as well as an incision in the lower abdominal wall, and then a exposure of the urethra and bladder. Essentially mesh tape is placed in through the vagina and through the anterior abdominal wall, through the rectus, the six-pack muscles, and then stitch in place to lift it back up. And incisions are closed. Obviously some downtime and healing that goes along with having a surgical incision inside your vagina, and often a catheter placed afterwards to help with urine flow. So those are some of the surgical procedures, and obviously there is significant healing and downtime that goes with those. Not procedures I personally do, but done by either urology or urogynecology. So other than surgery, minimally invasive options are injecting a bulking agent. So a scope is placed into the urethra and then it is injected here, again, to kind of pinch in and give support to the bladder neck. So non-invasive options are new technology. This is HIFEM technology, so high intensity focused electromagnetic stimulation. And we know that turning magnets on and off generates an electrical current that can lead to muscle contraction. And of course we use magnets in medicine for all sorts of stuff, including MRI imaging. We can generate a stronger muscle contraction and contract the muscles more quickly than if you're just doing it voluntarily. And we can aim it at those deep pelvic floor muscles. So it's aimed about 10 centimeters up, which gets into that deep pelvic floor muscles, unlike our TENS. And this can lead to improved support due to improved strength. And this technology can do approximately 11,000 Kegels in 28 minutes. So you remember that I told you that the Mayo Clinic wants us doing 45 a day. They thought that that was something reasonable that women could be expected to do. So it would take you, what, 240 to 44 days to do 11,000 Kegels that is being done in 20 minutes. So here is an example of how the technology works. And it is a chair, and the chair has the magnetic coil in the base. It is focusing, as I said, about 10 centimeters up into that deep pelvic floor and leading to contraction of those muscles to help them strengthen. This is an ultrasound showing that muscle actually contracting in real time. And again, you remain fully clothed, nothing inserted inside, and you can sit quietly in a room in private, which many women appreciate. So what are the pros and cons of our HIFEM technology? So as I mentioned, we're getting a correct contraction technique. We're getting more gain, more strengthening than we can do on our own. Non-invasive, nothing inside of you, fully clothed, no downtime at all, no risks like are associated with having surgery. It can be used preventatively, so for women who don't yet feel like they have an issue, we want to keep that pelvic floor strong. It can be used in that postpartum period to help strengthen things back up, and in postmenopausal women and perimenopausal women as those tissues are starting to change and become relaxed. Cons, okay, cannot use it when you're pregnant. You can't have metal because, as I said, it's a magnet. You can't use it if you have a cardiac pacemaker or defibrillator or some sort of implanted metal port in you. It will not replace surgery if you have a high-grade prolapse. So you remember that picture I showed you where the uterus was basically coming out of the vagina. This will not replace surgery. You know, if that's the stage you're at, you absolutely have to have surgery. And it will not treat incontinence or pelvic floor issues caused by intense pelvic floor. And in some women, they can get urge incontinence and outflow issues from tensing pelvic floor as opposed to relaxing pelvic floor. So think about when you get tension in your neck and your back and your shoulders, and it can be sore and it can cause numbness and weird feeling down your arms. If we are tensing the pelvic floor, we can't relax to get the pee out correctly. It can lead to those overflow obstructive kind of symptoms. It can lead to pain with sex. So again, really, really important to be evaluated by a medically trained professional who can tease this all apart and make sure we're getting the correct treatment for you. Not something that can be evaluated in a non-medical environment. What are some of the side effects? So maybe increased sexual sensitivity. We think maybe due to increased blood flow in the area. If you use it while you are on your period, we can trigger increased menstrual cramps. And as I said, increased tension in the floor of those who already have what we call a hypertonic or spasmed pelvic floor. So again, a reason why you need to be medically evaluated choosing treatment. Frequently asked questions. So how many sessions? Usually 6 sessions spread out over 3 weeks. And then because we need to maintain strength in our pelvic floor, top-up sessions, maybe 1 or 2, anywhere from 4 to 9 months, depending on the person. Again, you are fully clothed, nothing internal. It does not hurt. Feels funny. You definitely feel something happening, but it's not painful. There's no downtime. Obviously, you can't use it when you're pregnant, and we prefer you to wait approximately 6 weeks postpartum to make sure any tears, lacerations, or episiotomies are well. How does it differ from TENS or Dr. Hose? You know, I have people ask me, isn't this just a fancy Dr. Hose? Well, there's a study in the American Journal of Physical Medicine and Rehabilitation that looked at HIFEM technology, comparing it directly to TENS, and what they found was that HIFEM induced 2 times higher peak torque contraction than TENS, so 2 times higher contraction of the muscle. It penetrated much more deeply into the tissue than TENS, and remember, we're targeting that deep pelvic floor. No pain, sometimes TENS can be painful, and no risk of burns with HIFEM compared. So in summary, we have reviewed the complex anatomy of the pelvic floor and discussed how all of the tissues are impacted over the course of a woman's life by aging, by childbirth, by trauma and hormone changes, and that weakness of the pelvic floor is very common in women. Anywhere from 25 to 45% of women suffer from an oops or a leakage or some sort of dysfunction. And most women, you remember I told you in the beginning, are unable to voluntarily perform a proper Kegel exercise in order to strengthen the floor. Because pelvic floor dysfunction can be multifactorial, there's many different things that can lead into it, a medical assessment is necessary to determine which approach is best for you. There is no one-size-fits-all approach. HIFEM technology, our new technology, is very effective in properly selected patients. It's non-invasive, it's easy, it fits into busy lifestyles, and it can be used preventatively. It can be used in the postpartum period. It can be used in perimenopause or menopause or in symptomatic. So that is it for our presentation today. If you have questions, please make sure to message or email, and I will be happy to answer them for you. I hope that was useful and that you learned something, and that everyone will now take their pelvic floor health seriously. Thanks, everyone.